watching the room get filled up here with participants. And with us this evening, I'm just absolutely thrilled to be able to introduce my colleague, my friend, longtime educator in voice and voice disorders, Dr. Julie Barkmeyer Tremor. We were just talking about how long we've been able to be in the field together as colleagues and can't believe how much time has flown by. But if I took the time to read through Dr. Barkmeyer Tremor's CV, we would probably consume half of the time of the webinar, and I want to be able to get started. We're in for a real treat. Dr. Barkmeyer Tremor has been in the area of voice for a long time. I mean, she's been honored by ASHA. She is a longstanding research and scientist who, if you look through her curriculum vitae or CV, you'll see that she has been continuously funded by the National Institutes of Health, the NIDCD division for work in voice, work in vocal tremor, work with breathing and voice. And as a reviewer herself, she's been of great service to the field. She's a full professor working in the Department of Otolaryngology. She's a teacher for students learning speech language pathology, and probably one of the most kindest colleagues that I have had in my career. And Julie, I'm just thrilled because this work you're doing on vocal tremor is, I think, might be changing our field a little bit in terms of how we're going to go about classifying vocal tremor. And I know in your history, you really have understood the importance of the respiratory system and really being the driver of voice and speech and resonance. And I know that there'll be some tie into there, but I'm really interested on this work that you're doing. It's really novel. And I'm going to turn the mic over to you. And when you end, I'll be fielding some Q&A from the audience and asking you some questions as well from my own thinking. But thank you again for taking your time with us today.
Well, thank you, Chris. I'm very honored to be here. Thank you so much for such a lovely introduction. I need you to follow me around where I go. That was so nice. And thanks for letting me speak on one of my favorite topics. The topic is on systematic assessment of vocal tremor to help with improved classification and treatment of hyperkinetic speech disorders. I will be focusing mostly on vocal tremor, but I'll link it with some other hyperkinetic speech disorders as I go along. The learning objectives are, by the time I finish, I'm hoping you'll be able to define clinical characteristics associated with vocal tremor that inform its classification, and describe recommended clinical assessment approaches that help with identification and characterization of phenotypes of vocal tremor, and also to be able to identify and discuss the utilization of assessment findings to inform optimal treatment. These are my disclosures, which I will not belabor in the interest of time. And I would also like to just acknowledge the Voice Airway Swallowing Translational Research Lab. This is not a complete picture of everybody either, but we have just an amazing group that I want to credit with a lot of the thinking and the work that has gone into what I'll be sharing with you as an update of funded work and its impact on our recommendations for clinical practice. And I'll start with posing what is the problem we're trying to solve. And the problem is that vocal tremor, a much more prominent voice problem, is often confused with another hyperkinetic dysarthria that is more rare, laryngeal dystonia. And so let me give you an example. I know that we have a mixed audience, and so I'm not sure everybody knows what laryngeal dystonia is. Historically, it was referred to as spasmodic dysphonia. The updated nomenclature recommended by a consensus group of multidisciplinary experts is to refer to laryngeal dystonia. It is a neurologic voice disorder, as is vocal tremor. And the characteristics are intermittent and task specific. So typically in these individuals, when they cough or laugh or have emotive speaking, their voice can sound normal. They can have islands of normal speaking, and then suddenly they have these aberrant, strangled voice stoppages, or they may have breathy breaks. And here's an example of someone with laryngeal dystonia.
Tom wants to be in the army. We eat eels every day. He was angry about it all year. I hurt my arm on the iron bar.
So that is a classic example of an adductor type of laryngeal dystonia. And unfortunately, we have been finding that a lot of individuals who actually have vocal tremor are being diagnosed as laryngeal dystonia when they actually have vocal tremor as the prominent feature. And it's because they can sometimes, in severe cases, sound very similar to laryngeal dystonia. Here's an example of a case with essential tremor that affected their voice, and they actually came to us with the diagnosis of laryngeal dystonia.
How hard did he hit him? We were away a year ago. We eat eggs every Easter. My mama makes lemon muffins. Peter will keep at the peak.
And so you can hear that that is an individual who also is having some shakiness in their voice, and their breaking of voice stoppages occurred in a fairly rhythmic fashion. So they do have distinguishing features, but those voice stoppages can get confusing because of the overlapping features. When you do have somebody in your hands who has laryngeal dystonia, there are other overlapping features. This pie is showing you that the vast majority of those with the classification of laryngeal dystonia have the adductor type, the example that I played for you. There's a smaller proportion that have the abductor type, where the vocal folds abduct, giving breathy breaks when they're voicing. They sound quite different. I'll have examples. And about a third have a co-occurring vocal tremor. So that's another feature that can sometimes throw people off. So here are some classic examples where there is not vocal tremor in their voices. Here, the first example is another person with adductor laryngeal dystonia, and a fairly classic example. They're going to have intermittent voice stoppages and a strained, strangled voice quality.
Take the shape of a long round arch with its path high above, and it takes its two ends beyond the horizon.
Notice that sustained phonation sounded pretty normal. Now, here is somebody who has classic examples of the abductor type of laryngeal dystonia. They're going to have the underadduction of their vocal folds, resulting in breathy breaks during voiceless phonemes.
East take the shape of a long round arch with its path high above and its two ends apparently beyond the horizon.
Now notice both of those individuals had a fairly normal sounding sustained phonation. Now here's somebody with vocal tremor.
The blue spot is on key again. How hard did he hit him? We were away a year ago. We eat eggs every Easter. My mama makes lemon muffins. Peter will keep at the peak.
So hopefully you can appreciate that during the connected speaking, there was some similarities with that individual with vocal tremor, but the sustained phonation is really where we can hear that vocal tremor modulation more clearly. So vocal tremor more generally, we perceive it better during sustained phonation. You'll hear modulation of pitch and loudness, and we can actually measure that acoustically as the rate of the modulation and its extent or magnitude. These individuals also have been studied and shown to speak more slowly than normal speakers at a rate of about 3 versus 5 syllables per second. And some individuals have an alcohol responsive tremor, where they may report that when they have alcohol consumption, their tremor will get better or their voice sounds better. But if they have a severe vocal tremor during connected speech, you may also appreciate this overlap of voice stoppages or even breathy breaks, distinctive from laryngeal dystonia in that they occur more rhythmically. They can also be observed if you have access to endoscopy to occur with structural oscillations. Now, this confusion between these groups has been long-standing. Here's a publication from 2001 with Christy Ludlow, Jim Case, and myself. And at that time, we were trying to train individuals on how to perceive in auditory perceptual examples the kinds of signature features to listen for that distinguish between spasmodic dysphonia, that we now call laryngeal dystonia, and vocal tremor. And although that has been ongoing for a long time, we have a publication here from 2018, and if you know any of these voice experts listed as co-authors, these are experienced specialists who participated in a Delphi panel model trying to identify what were the signature features that distinguished individuals with laryngeal dysphonia from other voice disorders. And they had a less than 50% chance level of agreeing with each other. And so without having anchors or standardized criteria, even experts don't agree on how to classify these individuals. And the consequence of this is really important. We have unclear distinctions between vocal tremor and laryngeal dystonia in our literature. If you read the literature on laryngeal dystonia specifically, there are very poor descriptions of how individuals were classified. They mainly go by diagnosis, which might be wrong. And as a consequence of that, clinically, there are significant delays in accurate diagnosis and effective treatment options for individuals who are affected. And our literature has mixed patient populations without clear clinical features identified. This has affected how we characterize the epidemiology of these disorders. There's a lot of variability in how we identify and describe brain regions and circuitry associated with the pathophysiology. And the treatments that we're trying to innovate for these patient populations show variable treatment outcomes, likely because we are mixing apples and oranges together and we're getting variable treatment outcomes because we have different patient populations that we're studying. As a consequence of this, I'll throw out an example here that we've been using Botox injection treatments since the 80s. And still to this day for laryngeal dystonia, don't have a better option to offer. So I think if we could be more clear with our precise diagnosis, it would really help advance the science as well as our clinical practice. So one of the proposed solutions was published in 2021 with a consensus group. This was from an activity that the NIDCD sponsored from the National Institutes of Health. And you can see that there are experts from multiple disciplines represented here. And we all agreed that one of the biggest priorities right now is to identify disorder-specific biomarkers that we can use to help better classify our patient populations so that we can go on to develop these novel treatments that are greatly improved and help us with improving how we diagnose these individuals. So what I'll focus on here is the grant that we're funded to characterize individuals who have essential tremor. So that's what we've been focusing on mostly. And we're also part of a Project Center grant that also studies laryngeal dystonia and other forms of tremor. So I want to acknowledge my whole team here. We have an incredible group, and our research goal is to characterize the clinical features of vocal tremor in those with essential tremor. But I also want to acknowledge that we are also studying laryngeal dystonia and other forms of vocal tremor. And we're basing our classification criteria on a combination of features. We primarily, for tremor, are utilizing this updated criterion for classification of tremor published in 2017 by Bhatia et al. And it was an updated Movement Disorder Society consensus statement on the classification of tremors. And so to that definition, tremor is defined as an involuntary rhythmic oscillatory movement of a body part. It is one of the most common neurologic movement disorders. And the recommended treatment or the recommended classification now is based on clinical features and phenotypes as the primary way of classifying, followed by etiology. And the first feature to distinguish really is to identify whether the tremor is activated during muscle contraction or in rest when a limb is supported against gravity. So action-induced means muscle contracts either during posturing or during movement, like illustrated on this upper panel. And we're probably most familiar with Parkinson's disease for the resting tremor, like when a hand is supported against gravity or the arm, and you'll see that pill rolling tremor effect in the hands. Tremor is considered a syndrome, and so multiple classifications of tremor may have different etiologies. So we are recommended to really focus on the clinical features to help us with classification. This means doing a thorough medical history, including identifying if there's a family history of a neurologic problem, and also to note whether or not onset began after exposure to drugs or toxins. Then characterizing the tremor is really important, identifying what body parts are exhibiting the tremor, under what conditions you observe that tremor, and if you can, to estimate the frequency of the tremor. Now, movement disorder specialists do not have access to looking at the upper airway. And so these ideas about tremor affecting the upper airway have largely gone undescribed by the movement disorder experts. Frequency is usually observed by the motion of a limb that's affected or your head. And then noting whether there are associated signs like neurologic signs or other soft signs or systemic illness. And in some cases, doing additional laboratory tests may be recommended. So the Movement Disorder Society has kind of these 4 major classifications. I'll also note another form that they have identified that I disagree with, that we are spending some time characterizing. But essential tremor has been updated to be defined as tremor that begins bilaterally in the upper limbs, with or without head tremor or tremor in other locations that has been there for 3 years or longer, and in the absence of dystonia, ataxia, or Parkinsonism. This is in contrast to otolaryngology and speech-language pathology that classifies tremor affecting the voice as an essential vocal tremor, and we may or may not pay attention to whether there's tremor in the limbs. So I'll talk a little bit more about that. Essential Tremor Plus has all the same features of essential tremor, but there may be some additional soft neurologic signs that may be in progress. So that's just a way to note that there are additional things going on. Parkinsonian is usually associated with individuals either with Parkinsonism or Parkinsonian characteristics. And that would include a rest tremor, usually in the limbs, and dystonic. And dystonic tremor is very controversial. So this often is diagnosed in a structure that exhibits dystonia. Like for us, laryngeal dystonia would mean that the larynx has spasms intermittently. And then if you also observe tremor in the larynx, that would be tremor associated with dystonia or dystonic tremor because it's in a structure that has been identified to have dystonia. But dystonic tremor also is irregular. It can be intermittent. So there are some features to it that can be helpful clinically. We're studying essential tremor because it is the most common movement disorder in the world. 7 million people in the US may be diagnosed with it, and it tends to occur more in individuals who are 65 years of age and older. I've characterized that we now require that it's a bilateral action tremor affecting the arms and hands for 3 years or longer. And up to 40% of these individuals may have a co-occurring essential tremor. We've also identified that there are a large group of individuals where the onset of tremor may affect the voice first, and they come to see us, speech-language pathologists or otolaryngologists first, and they may or may not ever see a neurologist to get the essential tremor diagnosis. And that's who we're going to call isolated vocal tremor. Vocal tremor is neurogenic and, again, involuntary. So it's very distinct from vibrato, which singers do on purpose because they can turn it off. But in individuals with vocal tremor, they cannot. And it sounds like this. And you can hear there's modulation of pitch and loudness. This is an acoustic plot using the free shareware Prot. The blue is fundamental frequency. The green is sound pressure level, which corresponds with our perception of loudness. And then we also have plots of the formants, and you can see this kind of slow rate modulation going on. We can count the number of times that modulation occurs per second, and that will give us the rate. And we can also measure its extent or the magnitude of that modulation as a way of determining how severe is the modulation in the voice. And it's associated with individuals with essential tremor, dystonia, Parkinson's disease, all kinds of neurologic disorders have it. We're focusing mostly on essential tremor. But the Bhatia et al. Article talked about vocal tremor being isolated. What they meant by that was that when you hear vocal tremor, it's coming from the larynx. And I would argue that that's not true. And I think that's what neurologists think, because they can't look inside the upper airway. We can. And we know that vocal tremor is actually the result of tremor affecting the respiratory musculature, the larynx, and also articulators. In fact, we would also propose it's action-induced, because you can't really, sorry, I'm going to have a sip of water. You cannot really support the structures of speech against gravity while we're talking. And even when we're quietly breathing, we posture our upper airway to create patency so we can breathe. So we're either posturing or we're moving our structures during speech. So therefore, vocal tremor has to be action-induced. It's either during posturing or it's during speech. And Brad Story and I published in the ASHA Leader our model of vocal tremor that we're evaluating now. And our proposal is this: if the respiratory system is oscillating because the musculature has tremor, you're going to compress and expand our chest wall in a way that will affect subglottal pressures, and that will manifest in the acoustic signal like a sound pressure level. So this is Brad Story's simulation of what that would sound like. Hopefully you can perceive slightly that change in loudness that's being modulated. The larynx has three ways it can contribute to vocal tremor. One way is through the intrinsic muscles. So here you see the thyroarytenoid muscle of the vocal folds, and it goes along the length of the vocal folds. And so when there is tremor affecting either that muscle or the cricothyroid that elongates the vocal folds, the thyroarytenoid shortens, you'll get a length change that will occur in an oscillatory way, and that will affect the fundamental frequency or pitch like this. And then the posterior musculature, like the intra-arytenoids and the adductors posteriorly, can cause the vocal processes to come together and apart so that the glottis changes its width in an oscillatory fashion. And we actually see this most commonly in individuals with tremor. What that glottal width oscillation is going to do is cause loudness to be modulated, or sound pressure level, and it would sound like this. So you can kind of hear an introduction of some breathiness. Now, the third way the larynx can contribute is the length changes of our vocal tract, or that airspace formed by the upper airway articulators. The vocal tract could also change its diameter anywhere along the length as well. And when that happens, it's going to shift the harmonics that are being created in our voice. And we measure those by formants. And we particularly study formants 1 and 2 in the acoustic signal. But this is what that would sound like if we model what that diameter change sounds like in the oropharynx. So during the pandemic, after we got funded to do our work, of course, our human subjects work got shut down. So one of the best things that happened to us was that, because we did this retrospective electronic medical record review of individuals with vocal tremor who were documented with vocal tremor anywhere in our medical system. And our purpose was to see if we could characterize, using the Bhatia et al. Classification of tremor, and also some of the clinical features that the Academy of Otolaryngology published in their neurolaryngology paper from 2005. we wanted to see if we could characterize individuals with vocal tremor who were not necessarily seeking treatment for vocal tremor. So they could have been seen by neurology and documented with vocal tremor, or by our voice experts. We just wanted to find anyone that was documented with it, and then observe the clinical features that were documented by the providers to see if we could classify them. And what we assembled between the Bhatia et al. Classification criteria and the Academy of Otolaryngology's were these. We have essential tremor, so you had to meet the Bhatia et al. Diagnostic criteria for essential tremor. What we're calling isolated vocal tremor is somebody who did not have the diagnosis of essential tremor. They had no other neurologic diagnosis, but they have the structures of the speech structures affected by tremor, with no other co-occurring neurologic comorbidities, and we could observe tremor in any of the speech structures. Dystonic tremor usually was associated with individuals who presented with characteristics of laryngeal dystonia or characteristics of dystonic tremor without a diagnosis of essential tremor. Parkinson tremor, indeterminate, means that it had all the features of essential tremor, but it didn't meet all of the criteria, usually meaning it had just come on and they didn't have 3 years of duration, or we couldn't classify them at all. And we found that neurologists were really good at documenting all these clinical features associated with individuals who had vocal tremor. But otolaryngologists and speech-language pathologists were not systematic at all. About a third of all of the patients that we identified with vocal tremor in our system who met our inclusion criteria were not able to be classified at all. And almost 50% were classified solely based on their neurologic comorbidity diagnosis, not necessarily clinical features. So for example, if somebody did not comment on jaw tremor, we did not know whether that was because they had not assessed it or they just didn't observe it, because we don't do standardized assessment. So this made us think about putting together a systematic assessment, which we did and we published. And the clinical features that were needed was a way for us to systematically document what body parts did we test. We need to comment on symmetry, right versus left. What was the task going on that was associated with the activation of the tremor? Were they breathing? Were they doing speech? Or was it not task specific? And if we could, we'd estimate frequency, which often came from our acoustic measures, which unfortunately doesn't tell us the rate of a tremor of the body part, because basically the acoustic signal is a summation of the output of the signal, not necessarily the sources themselves. And here's, we've worked with this systematic assessment now for a couple of years, and we've revised it and fine-tuned it. So we actually basically took a neuromotor speech assessment, a very standard neuromotor speech assessment, and organized it by how we test sensory, and we added taste because we aren't very good about documenting taste or touch in our sensory motor testing, as well as motor. And you can see just the upper part of one of the forms. It identifies some of the body parts we're testing. We identify the task we're doing, and then we document the symmetry of the findings, normal or abnormal, and have a space for commenting. And then similarly for motor testing, the structure that we're testing, we identify the task we're doing. We mark if it's normal. We mark if the structure exhibited tremor for a given task. And then this dystonia box is to indicate if that structure is known to be diagnosed as having indications of dystonia. And that's how we indicate whether or not it's a tremor associated with dystonia, and then have additional location for indicating comments. And what we found, we went back, because this does require us to have nasoendoscopy imaging to extract clinical features. We went back to our original cases and found 81 where we had nasoendoscopic examinations. And we went through all of those 81, and this is if we only took the 81 from the original total group. this is how our classifications would have looked. Then we applied our systematic testing to see if we could improve our extraction of clinical features. And we went from 22% in those who had nasoendoscopy to only being able to being only unable to classify about 5%. And you'll also notice that dystonia remained the top classification, but what we called isolated vocal tremor represented the next highest group. Essential tremor was third, and then Parkinson's disease, indeterminate, ET plus, and then other. So basically using that systematic approach, we were better able to identify a classification. Still remains to be seen if we were accurate. Our team actually is composed of movement disorder specialty, otolaryngology, and speech language pathology. So we did get some consensus across our team members for this one, that this manuscript will be coming out shortly. And so what we've put together is a proposal of clinical methods for helping improve or reduce the misclassification of those with vocal tremor. And so here's what it consists of. First off, I know it's not possible for everybody to work with multiple disciplines. Ideally, if you can coordinate care across multiple disciplines, we have found our movement disorder specialists to be incredible contributors to our team. And so we do a thorough case history. We've now developed this systematic assessment. When we have somebody who has tremor or a movement disorder, we add this to our repertoire of what we administer. And then auditory perceptual features, nasoendoscopic, and we do acoustic analysis, which we find highly diagnostic of vocal tremor, even better than our ears. The auditory perceptual evaluation has been published previously by Ludlow et al. And it basically means if you systematically ask individuals to sustain phonation of vowels, we use A and E to get the spectrum from lax to tense. We also have them talk at a high pitch and shout, and that's for differential diagnosis of laryngeal dystonia. Similarly, we do the same with counting from 60 to 70 and 80 to 90, again, as a way of looking at distinguishing phoneme specificity. But keep in mind, vocal tremor can only be heard during voice phonemes. So if you hear voice phonemes, which is signature of the highest probability of adductor laryngeal dystonia among those who have it, it is not a way of distinguishing between vocal tremor and laryngeal dystonia itself, but it does help you listen for the strained, strangled quality of laryngeal dystonia. And then instead of having individuals read sentences, we have them imitate them back to increase their cognitive workload. That's really important if you think someone has laryngeal dystonia. And these are the sentences from the 2008 publication from Ludlow that help with distinguishing the voiced and voiceless patterns of symptoms. And then there's judging vocal tremor severity. So let me play sustained phonation in two individuals, and I want you to see what you think about their sustained phonation vocal tremor severity. That's case one. 3 to 5 seconds. Okay, and now do the same thing with the sound E. Very nice. Now so if we were to say vocal tremor severity solely based on sustained phonation, we would probably perceive these two individuals to be similarly severe, probably moderately severe. But now let's listen to connected speech and see if you still think that. So here's case one.
The blue spot is on the key again. How hard did he hit him? Where? We were away a year ago. We eat eggs every Easter. My mom makes lemon muffins. Peter will keep at the peak.
And here's case two.
The blue spot is on the key again. How hard did he hit him? We were away a year ago. We eat eggs every Easter. My mama makes lemon muffins. Peter will keep at the peak.
Okay, So these two individuals definitely sound differently impaired under connected speech. And back in 2012, we published a paper illustrating this. We had 5 speakers, and our hypothesis was that vocal tremor would be much more perceptible when there's all voiced phonemes. And we didn't necessarily find that. What we found was individuals were differently impacted by their vocal tremor. We certainly had one individual who illustrated equal severity across all of the speech contexts. And then we had another individual who fit our hypothesis perfectly. But this individual largely sounded almost normal during connected speech compared to sustained phonation. And so this study actually was the first one to inform me about what we need to be thinking about when we classify vocal tremor severity. Severity really should be judged based on the combination of sustained phonation and connected speech. Sustained phonation is where you detect the vocal tremor, and that's one level of severity. That's really unleashing the vocal tremor. But then also judge the consistency with which you can hear that tremor during connected speech. If somebody has a mild vocal tremor, you may not even detect their vocal tremor during connected speech. It might also just be minimally evident to you. Severe individuals, it's pretty evident no matter what they're saying. And then those who are moderate are inconsistent, somewhere in between. You can definitely hear it during vocal tremor, during sustained phonation, but maybe not as consistently during connected speech, depending. So that's our recommendation for judging that. And then finally, you want to observe. You want to see those structures. And if you yourself don't do endoscopy, you'll want to partner with an otolaryngologist who does. If you suspect somebody may have laryngeal dystonia, we recommend that you minimize or don't use topical anesthesia in placing the flexible scope. So this is the kind of scope you'll want. This flexible scope goes through the nasal passageways so that an individual can be freed up in the oral cavity to be able to speak connected speech while you're observing structures in the upper airway. And it's very important that you do the speech exam tasks without the scope in place and then with the scope in place, because those who have a dystonia might find the presence of the scope to distract them, and their symptoms may sound a little better with the scope in place. And again, evaluate laryngeal function across the speech examination tasks as well as during vegetative activities, observing for the location of the tremor, the activation context if you observe tremor. And we also need to see about 4 cycles of respiration. And here's a little tip. Don't observe respiration while you're telling them what to say, because we're finding that individuals will be moving their larynx, imitating what you're giving them to say back ahead of them actually repeating it. The larynx is doing a little subliminal imitation of what the speaker they're listening to is saying. So it really has to just be quiet breathing so that you really know whether or not those movements you're observing are them cognitively processing what you're saying versus they're just quietly breathing. And you want to observe, usually with tremor, it will be during the adductor phase of the breathing where the vocal folds are coming back together. Note whether it's symmetrical, whether it's consistent, any of the conditions under which you observe it. And if you also vary pitch and loudness with tremor and observe when the tremor gets worse or better, that informs the muscles that may be affected by tremor in the larynx. That can inform Botox if they go on to have Botox treatment. So if you hear tremor worsen on a high pitch, likely the cricothyroid muscle is affected. If they worsen on a low pitch, the thyroarytenoid muscle may be affected, but also notice whether they're doing length change oscillations or are the vocal folds abducting and adducting. If they're abducting and adducting, the surgeon may want to inject Botox into the intraarytenoids instead. So that identification of the affected musculature is quite important. And as far as classification goes, essential tremor is often signified by an action tremor that is in somebody who either is diagnosed with essential tremor or they have a bilateral tremor in their upper limbs for more than 3 years. And you're observing the tremor in a lot of the upper airway structures. It tends to have a bigger spread. across tongue, soft palate, pharyngeal walls, and the larynx. If they haven't been identified as having essential tremor, we classify them as isolated vocal tremor, even though it's not really isolated to the larynx. But if they don't have a diagnosis of essential tremor, there's no tremor in their upper limbs. They don't have any other neurologic problems, but they do demonstrate a spread of tremor in the upper airway. I really think it's a variant of essential tremor that's begun in the axial structures of speech. And it often, in about 50% of those we see, will spread to the limbs eventually. But if it starts in the voice, it often just remains more prominent in the voice. If it started in the limbs, it can spread to the voice. It can be equally as bad as the limbs, but they'll have seen a neurologist first. Dystonic tremor tends to be characterized by a structure that's been diagnosed with dystonia, like in laryngeal dystonia, but it also tends to be more irregular. We've seen a lot of asymmetry in these individuals. I have an example I'd like to share with you. Here's an individual with adductor laryngeal dystonia. Here's her sustained phonation. You can't really hear. You can't really hear the tremor and the ah, but on the E, you can hear a little tremulousness. Here's her speech.
Sam has a rabbit in his hat. Jack ran to get an apple for Sally. Anne patted the fat lamb.
I guess that's that. Here's her endoscopy, and it's very subtle, but she has a pretty asymmetric tremor, and it's intermittently there. Hope it will play. All right, I'm right at the end. Well, it worked before. Wonder why it's not working now. I'm going to just see if I can get it to play here. Oh, darn it. It isn't playing. Cannot play the media. Well, darn. I'm sorry about that. Okay, well, I'll play one more. Sorry about those floating panels. But what you would have seen is just her left-sided pharynx oscillated and the right side not so much, and it was intermittently present. So I'm sorry that didn't work to share.
Sam has a rabbit in his hat.
She's doing a chorus all by herself. But here's a nasoendoscopy of somebody with essential tremor. And so that's the soft palate. We have the endoscope in the nasopharynx there, and you can see the soft palate right here in the bottom of the screen. And then here we are in the pharynx. The bottom of the screen is the front of her throat. Top of the screen is the back of her throat. This is the left side. This is the right side. And what you're going to see is her larynx, her pharyngeal walls, and the base of the tongue at the bottom will come into view and oscillate. Good. And now E at a high pitch. E. And E at a low pitch. Okay. Okay, now
The blue spot is on the key again.
we eat eggs every Easter.
We eat eggs every Easter.
Peter will keep at the peak.
Peter will keep at the peak.
All right, so critical findings are identify whether you can see whether there's a presence or absence of the tremor and signs of dystonia, but really important to characterize those tremor characteristics across body structures, symmetry, and activation conditions. And if they haven't been seen by neurology, think to test whether or not you see tremor in their limbs or their head, and ask them about how long it's been there, and do they have a family history of neurologic disorders? And compare between speech contexts when you judge the severity of the vocal tremor. If in doubt, I highly recommend voice therapy. Doing voice and speech therapy can be a diagnostic tool as well as a beneficial treatment, even if they have a disorder that can't be cured from speech treatment, which most of our neurodegenerative diseases are not. but it will help diagnostically and therapeutically. You can do some good in giving them strategies for relieving the excessive muscle tension, teaching them communication strategies for difficult speaking situations. And then for those with vocal tremor, we found it very helpful to improve respiratory phonatory coordination, to offload that muscle tension that activates their tremor, and also to focus on reducing voicing duration, like speaking like staccato-ish almost, to help with reducing the perception of the vocal tremor. So in summary, clinical features of vocal tremor require systematic testing and documentation. Clinical features should be based on updated tremor classification criteria so that we get better insights into tremor affecting the voice, and we're more precise with our differential diagnosis from other hyperkinetic disorders like laryngeal dystonia. And that will also inform improved treatment options. For example, those with tremor may also benefit from systemic medications in addition to the Botox options, as well as behavioral. All right, so with that, I will open for discussion.
Oh, thanks. I refer to you, of course, as Dr. JBK, Dr. Julie Barkmeyer Kramer. You know, seriously, Julie, that was incredibly articulate. And I would say for people that are listening in, those that I recognize that have a lot of experience, some that don't, this is very tedious work, what you're doing, and it's complicated. And mastering sort of the modeling that you're doing on the acoustic waveforms is just extraordinary. There's things here that I learned that I wanted to talk to you about. And there's a couple of questions here from the audience that I want to bring up in the time that we have remaining. And I also just wanted to say, you know, all the work that you've been doing at the Huntsman Cancer Clinic, everything you've been doing for people from those that have cancer to other types of voice disorders. Thank you for leading that charge. Really do appreciate that.
But I honestly am not with Huntsman.
Oh, I thought you were.
No, we tried to create a partnership, but they are administratively separate, which is new for me because I've always been in a center where we had, you know, head and neck cancer patients too.
Okay. Well, anyway, we appreciate you. Yeah.
They are wonderful though.
Here's a question from a respiratory person, because that just lit me up when you said that some of these things might be coming, and through the simulation you showed, directly from the respiratory system itself, from the respiratory muscles. And I remember, if I'm thinking of a paper a long time ago in the sort of middle 2000s from the Tom Hickson group.
Oh yeah.
Where they showed variations in alveolar pressure, you know, maybe as causative to tremor. Can you talk about that, given the fact that you showed how many systems are involved in?
Right.
Yeah.
And we're just mapping out right now, in those with essential tremor, we're trying to map out who is showing chest wall oscillation associated with the output. And not everybody is, but quite a few are. And so what we're trying to map out is which muscles are more likely to express with this tremor. It does tend to be the expiratory muscles, and so it is more manifest in most of the individuals as they get below resting expiratory level. It tends to be increased, which of course means it's being activated more. The muscles are more affected as they're running out of air.
Right.
And we've had a couple individuals who really are most bothered while they're at the top of their vital capacity, where the diaphragm brakes are on, the inspiratory muscles are trying to prevent the loss while they're sustaining a phonation. But that isn't as common. So in either of those cases, though, what we see is a slower rate sound pressure level modulation in the acoustic signal. It tends to be around 3 hertz instead of the 4 to 6 or 8 hertz for the larynx sound pressure level that's associated with this kind of motion of the larynx. So, I mean, I'm a practicing speech pathologist, and I want to be able to help, right? And we've talked about Botox as a, you know, option here, and I want to go back to sort of the misdiagnosis part. But I mean, what can we modify extrinsically then? I mean, is there a possibility that you can modify respiratory effort? Is there a possibility you can modify sound pressure level and tremor is going to be reduced? So here's what's so interesting. And I've always thought that it had to be someone who was more mild to moderately impaired who could respond to the behavioral modifications we do. But in fact, I just had somebody who was terribly severe, and she showed me she could be benefited very well. And she had a lot of respiratory involvement. And one of the big first things I do is have them work on really working with the respiratory apparatus to get the airstream going, because what they're doing is really focusing in the throat to
Right.
control more here, and that just increases the activation. And it was like session 3, she finally got it. She finally was being more inefficient with her airflow. And it turns out the respiratory involvement doesn't seem to impact as much as the other structures up above what we hear as tremor. The manipulation is really around voicing duration, shortening it.
Okay.
You can hear the vocal tremor if you get above about, if you can get them to shorten to about a half a second, that modulation. Speaking kind of like this, you can get them to shorten voicing duration, and it makes it so much harder to hear the tremor on the
Wow.
output. And I got
Okay.
that this gal her whole family has commented on how much easier it is to understand her now because they're not hearing the tremor as much.
Okay, so if you were to categorize sort of tools, then are you saying shorten the duration?
That's
Increase respiratory effort or not?
Yeah, it's I would call it increasing respiratory effort in the front end. What it really is re-coordinating the use of it as your power source.
Okay.
Because without that energy supply of the airstream coming through, the larynx is this variable resistor that increases its tension if you don't have an adequate amount of pressure driving it.
Right. So
So
step number 1, make sure you've got we're sitting at the right lung volume. You're not too high up in lung volume, and you're not getting people to breathe so far below
Yep.
resting expiratory level. And for the people, on the line, we as speech pathologists, we tend to always say, take a big breath in before you start. Well, that's not always the right tactic, because we're getting people checking the diaphragm and actually making it more effortful. So it's that mid-lung volume range, right, Julie, that you'd want to?
Yeah.
Okay.
That's right.
Yeah.
Yeah. Because there's
And-
another activation of action tremor if you go to too high.
Yeah, no, but I think that's important, because we've got to tell folks here kind of where they need to position people in the lung volume range, and then what strategies are you using to reduce the perception of the tremor?
Yep.
Because if not, you might leave the talk thinking that the only alternative you have is to somehow, put a paresis or paralysis into the structures.
Right.
Which, obviously is one alternative for some cases with mixed, but not
Mhm.
the end all be all. So I thought those simulations that you showed were, pretty
Aren't
extraordinary.
those great?
Yeah,
They
yeah.
sound like Brad's story too. They're based on his MRI.
Somebody wanted to know about, you made a point, this was more about the methodology, where you were saying, don't use a topical anesthesia during endoscopy. Why is that?
So topical anesthesia has the risk, if you think it's somebody who has laryngeal dystonia, that's our original motive. The topical anesthesia will create a sensory trick effect and make their symptoms go away. And my PhD student who just finished, Caitlin Dwinger, just did a master's thesis and a dissertation to show that those who have vocal tremor also have sensory modulation of their symptoms. They actually get better with the scope in as well. And topical anesthesia also improves their symptoms. So yeah, so
Which kind of goes along with the alcohol sensory depression as well, I would assume. Okay, that makes sense.
So I also saw somebody wondered how we handle that. So when we do minimal, we use viscous lidocaine, and we put it into a cup and put a Q-tip in it, and kind of like COVID testing, we figure out which side's more open that we're going to pass the scope, and we stick the Q-tip in and get the anterior nasal passageway meatus lubricated, and then we put a little bit more around the scope tip so that as the tip is going in, it will pass the remaining lidocaine along the nasal passageways that it's being passed. And that actually helps make them comfortable in the nasal passage without having it coat the structures of the upper airway. And it works very well.
Julie, let's go back to MTD for a second, because one of the things that I've always been fascinated with is a lot of the underlying, the base of the voice sounds the
Mhm.
same. You know, there's a strain that you always hear, whether there's a dystonia, whether there's an essential tremor. Is that an underlying MTD that you think accompanies all of this? Why is there such a similarity in the baseline voice?
Wow, that's a tough question. Why is there similarity? Well,
I
that
mean, yeah.
tension, I mean, I think that muscle tension dysphonia, I mean, one way of distinguishing whether it's laryngeal dystonia is, can you cure it?
Right,
Because
right.
muscle tension dysphonia is highly treatable and responsive to therapy, whereas laryngeal dystonia is not. And interestingly enough, most of our tremor patients don't have the same kind of muscle tension dysphonia characteristics, if any.
Mm.
When they do, it's easy to offload, and then it really unleashes the tremor underneath. So it seems to go more hand in hand with laryngeal dystonia. Interestingly, it gets released when you really shout or go to a high pitch for some reason.
I was gonna ask you that. So what is the stimulability testing that you do to see if you can offload MTD? What do you do clinically?
Yeah, so for MTD, we do several different things. So stimulability testing can be varied, but we do use the high pitch. We could use resonance changing, forward focus. Our team is also trained by Nelson Roy, so he likes laryngeal manipulation.
Right.
They get really instant results practically with that.
Okay.
So a whole range. And in fact, Liz Young is a PhD student in our program, and she's investigating systematic use of stimulability to try to create more consistency in how we use that for our assessment outcomes and judging whether someone's a good candidate for tremor or
Yeah, I think that's an important contribution. That's excellent. Somebody wanted to know, you're using Pratt. They
Oh,
said,
yeah.
are you counting the modulation of both frequency and intensity? And do you have a diagnostic threshold?
Such a great question.
Yeah.
So the answer to the last question is we hope to have that in the upcoming year. We've been partnering with Yori Marin, who has the Phonanium program, which has a bunch of tool sets that engage with Pratt as added tools for extracting acoustic measures. And his Phonanium has been, his algorithms have been revised to match our manual extraction of rate and extent of acoustic tremor measures. And he's got the highest agreement. The KLMetrics CSL does not, the ADS,
Okay.
I think it is, does not. They're
Mhm.
using other features. But we do, yes, count the rate per second of a representative segment of where the modulations are occurring. We look at fundamental frequency and sound pressure level, basically. And then we also plot formats 1 and 2. In fact, we've got a paper we're putting together to show that that alone is diagnostic of whether the tremor is isolated to the larynx, or if it's also affecting structures outside of the larynx. If the formats 1 and 2 are modulating, it tends to indicate that base of tongue and pharyngeal walls are involved. And the soft palate doesn't have a whole lot of impact, interestingly, on the acoustic output. And then the larynx rate and fundamental frequency and sound pressure level modulations tend to be measurable as well. And so we do count the rate of the modulations, and then our extent is kind of the modulation equation, where we subtract the max, the min from the max, and then we add those two together. We do the ratio of the difference by their sum times 100. And you can do that with fundamental frequency, but sound pressure level is logarithmic, so you have to put it on a linear scale. So we convert it to pascals before we do that measurement.
And can we find that in your published work?
The 2012
methods?
publication with Amy
Okay.
Letterly, we do that. And then I think Rosemary Lester's publication from her dissertation also may go through that.
I wanna tie up with a question here at the end, and that is, when you looked at your systematic